Important ECG findings in patients with syncope. Syncope is an uncommon problem seen in urgent care practice, and most cases of syncope are self-limited and benign. Transient loss of consciousness is, however, occasionally a harbinger of a more severe underlying problem. Coronary ischemia, cardiac dysrhythmia and the potential for dysrhythmia, and cardiac outflow obstruction are among the cardiac causes of syncope that need to be considered when a patient presents after syncope, regardless of the healthcare setting. The following review summarizes the major conditions that need to be excluded by ECG for patients who present after having passed out. Coronary ischemia. Syncope associated with coronary ischemia can have many causes, including paroxysmal dysrhythmia, left ventricular pump failure, and acute mitral regurgitation. Careful cardiac and pulmonary physical exam may be revealing in these cases. As well, the clinician should review the 12-lead ECG for signs of ischemia. These include new and evolving T-segment changes, T-wave inversions, and/or Q waves. Comparison with any prior ECGs can increase the specificity of any abnormal findings for an acute problem, as can obtaining a second ECG in clinic 10 to 15 minutes after the first for stable patients. The sensitivity of ECG is less than perfect, however, so patients with a presentation that is clinically suspicious for ischemia should be promptly and safely transferred to a higher level of care, even with a normal or unchanged ECG. Brady and tachycardias arrhythmias. Bradycardia results in syncope due to directly decreased cardiac output. A slow heart rate should be obvious on ECG and may be due to sinus bradycardia or first, second, or third degree heart block. Sinus bradycardia and lower-grade heart block, for example first or type I second-degree heart block, may be transient and generally carry a lower risk of adverse outcomes than higher-grade heart block, for example type 2 second or third-degree heart block. Sinus bradycardia or even lower-grade heart block may be seen as part of a vagal response, and any slow heart rate may be due to intrinsic conduction system disease, medication, for example calcium channel blockers and beta blockers, or hyperkalemia. Patients with persistent, symptomatic bradycardia of any sort or high-grade heart block even without symptoms generally require transfer to a higher level of care and may be candidates for pacemaker placement. Associated symptoms are a more important criterion for pacemaker placement than heart rate, though documented periods of asystole for 3 or more seconds or any escape rate below 40 beats per minute are significant in asymptomatic patients. Those with asymptomatic sinus bradycardia or low-grade heart block should be managed in consultation with a cardiologist, and most can have outpatient follow-up. Tachycardia results in syncope when the heart rate reaches a threshold above which inadequate time for ventricular filling lowers stroke volume below a critical, brain perfusing level. This threshold rate will be lower for patients with many types of underlying cardiac disease. Ventricular tachycardia or very rapid supraventricular tachycardia cause syncope more often than atrial fibrillation, atrial flutter, or multifocal atrial tachycardia do. Of course, any culprit dysrhythmia may have resolved by the time the patient presents for care to an urgent care clinic. It may recur paroxysmally and be captured with monitoring in clinic, but more often, the clinician must examine the ECG for conditions that predispose to tachycardias arrhythmia. As with ischemia, ECG sensitivity is too low for it to be relied upon to completely rule out a potential rhythm problem, particularly in an asymptomatic patient after syncope has resolved. Therefore, for patients with worrisome presentations, such as syncope during exercise or prominent palpitations preceding their syncopal episodes, the urgent care clinician should coordinate disposition and follow-up with a cardiologist, even if the 12-lead ECG in clinic is normal. Conditions which predispose to dysrhythmia. Several conditions, in healthy patients without structural heart disease, are associated with a predisposition to tachycardias arrhythmias and syncope. These conditions are also associated with sudden cardiac death, so clinicians should look for the ECG findings of these disorders in all patients who present after syncope. Clinicians should immediately consult a cardiologist for any patient with any of these ECG findings after syncope. Hospital admission for telemetry and electrophysiology study is often advised. Any of these may be found on routine ECG as well, and without a history of recent or prior syncope, an outpatient workup can be pursued. The occurrence of syncope, however, portends higher risk, and these patients need immediate, or at least extremely close, specialty follow-up. Long QT syndrome. Several abnormalities of delayed ventricular repolarization are characterized by prolongation of the QT interval on ECG. These abnormalities include congenital membrane ion channel defects and some acquired causes related to medications, toxins, and neuropathies. Any of them may result in spontaneous or provoked, for example at the sound of a loud noise or physical or emotional stress, ventricular tachycardia, which can degenerate to fibrillation. The median age of those who die from LQTS is 32 years old. Delayed ventricular repolarization is defined relative to heart rate, and LQTS is characterized by a QTc interval greater than 440 to 450 milliseconds in men and greater than 460 milliseconds in women. A general impression of whether the QTc is prolonged can be obtained by looking for the end of the T wave. If it occurs over halfway between the RR interval, then the QTc will be prolonged. Brugada syndrome. Patients with Brugada syndrome have a defective sodium membrane channel due to an inherited chromosomal mutation. The defective channel predisposes to ventricular tachycardia and fibrillation. The ECG hallmark of this disorder is a right bundle branch pattern with anterior ST segment elevation in either a curved down-sloping or saddle-shaped pattern. The mortality of undiagnosed, untreated Brugada syndrome is reported to be 30% at 2 years. The average age at diagnosis is between 35 and 45. The ECG findings may be transient and are reported to be unmasked by fever or some medications. Ventricular pre-excitation syndromes. Several mechanisms of supraventricular tachycardia exist, but those which incorporate conduction along an accessory pathway can permit SVT rates and other situations that are more likely to result in syncope. If the resting ECG captures conduction of the atrioventricular impulses along the accessory pathway, the classic pattern of Wolff-Parkinson-White syndrome will be apparent. This includes shortening of the PR interval to less than 120 milliseconds, widening of the QRS complex, and a delta wave, which describes a slurred upstroke of the initial part of the R wave. Cardiac outflow obstruction. Another genetic disorder, hypertrophic cardiomyopathy, comes in several forms, all involving abnormal left ventricular hypertrophy. Many patients will never have symptoms, but there is potential for the hypertrophied segment to obstruct the outflow of blood from the left ventricle, particularly during exercise. This can lead to syncope or worse. HCM is the most common cause of sudden death in young athletes. ECG findings include LVH and/or prominent Q waves in leads 2, 3, AVF, V5 and V6. The ECG is reported to be abnormal in about 90% of patients with HCM, so examining for abnormal Q waves and/or LVH in someone who has no reason to have it is important when evaluating a patient post-syncope.
Audio Jungle. Audio Jungle.